All right. Welcome, everyone. I'm Sophie Hogeveen, Data Access Officer for the Canadian Longitudinal Study on Aging, or CLSA. Thank you for joining us for this webinar today, Sociodemographic Determinants of Mobility Decline Among Community-Dwelling Older Adults, Preliminary Findings from the CLSA. Before we begin, I want to acknowledge that the CLSA National Coordinating Center and McMaster University are located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. The University of Lethbridge is located in traditional Blackfoot Confederacy territory. We honor the Blackfoot people and their traditional ways of knowing and caring for this land, as well as all Indigenous peoples who have helped shape and continue to strengthen our university community. As attendees of this webinar, I encourage you to continue your learning following the webinar and to acknowledge the original inhabitants of the lands where we currently have the privilege to research, live, and work, wherever that may be. Now, before we begin, let's review a couple of housekeeping points. Everyone but the presenters will be muted throughout the webinar. If you need to change or test your audio during the webinar, you can click Audio Settings on the bottom of the Zoom window. At the end of today's presentation, there'll be a question and answer session. If you have a question for the presenter during the webinar, you can post it in the Q&A box located in the bottom toolbar. So that's different from the chat box. It's the separate Q&A box. The questions will be addressed at the very end of the webinar, and your questions will be visible to all attendees. If you have any technical trouble concerning the webinar, please use the chat box to communicate with the webinar team. A feedback survey will be launched at the end of the webinar, and we invite you to complete it after exiting the Zoom session. This brief survey provides us with important feedback we can use to plan future CLSA webinars. So as I said earlier, the webinar for today is titled Sociodemographic Determinants of Mobility Decline Among Community-Dwelling Older Adults, Preliminary Findings from the CLSA. This webinar will be presented by Dr. Ogochukwu Onyeso, a population health researcher with a focus on aging, mobility, long-term care, and the social determinants of health. He recently completed a PhD in population studies in health at the University of Lethbridge, Alberta, where he was awarded the prestigious Governor General of Canada's Academic Gold Medal and the Medal of Merit from the School of Graduate Studies. He is also a fellow of the Consortium on Analytics for Data-Driven Decision-Making. All right, I'll turn it over to you.
Thank you. May I start sharing my screen? Okay, is everything okay from your end?
Looks good to me.
Okay, thank you, and I welcome all participants. I'm very grateful that you joined us today. So I am talking about sociodemographic determinants of mobility decline among community-dwelling older adults, a finding from CLSA. So I thank you again, Sophie, for that wonderful land acknowledgement. So I want to acknowledge that this work was completed in the University of Lethbridge. So we honor the Blackfoot people and their traditional ways of knowing in caring for this land, as well as all Indigenous people who have helped shape and continue to strengthen our university community. So I also want to tell you that this is a part of my PhD thesis, which also has other parts that are, some are published and some are under review. So I'll be mentioning some parts of other papers also to just bring more context to what we're talking about today. But this very presentation has already been published in the BMC Geriatrics. So this is an outline. We'll start with introduction, have a little reflection on mobility, and go all the way to question and answer. So I have a QR code here, which If you scan, we'll take you to the published paper in case you want to follow the published paper too, because there are very large tables there that will not be able to fit into slides today. But I'll do my best to make a summary of everything. So, as we all know, the population of older adults 65 years and older is increasing globally. But it's important to note that WHO uses 60 years and older for their own benchmark. And they said that this number was about 800 million people, 12% of the global population in 2015. And I have a projection that this number will go up to 2.1 billion people by 2050. So the Canadian census has shown us that 19% of Canadian population in 2023 were people 65 years and older. And there's a projection by Statistics Canada that this number can go up to 25% of Canadian population by 2050. This is about 1 in every 4 Canadians will be 65 years and older. And as the aging population, as the number of older adults increases globally, we also expect that age-related mobility limitations will also increase. So today we're talking about mobility. Mobility has a lot of aspects. So today we're talking about active mobility, which includes walking, community ambulation, which could be assisted or unassisted. So today we're not talking about the motorized form, transport, or driving. So we'll say mobility is a person's ability to move around safely and independently, with or without a walking aid. So as a form of reflection, mobility is not just the ability to move, but the essence of autonomy, dignity, and participation. So when mobility is limited, the journey of life itself becomes constrained, demanding resilience and adaptation in the face of aging. So why is it important to look at mobility in older adults? It's because other researchers have shown that mobility impairment leads older adults to physical disability and institutionalization, frequent falls and injuries, sedentary behaviors and dependency, depression, social isolation, reduced quality of life, and even death. So in 2012, 20.6% of Canadians aged 65 years and older reported mobility limitations. And we know that this trend increases with age. So because of that, we thought that an interplay between the human anatomical structures, physiology, and some biochemistry would position the human body to be able to execute transfer from a stable position to both dynamic and static balance, and also propel the human body to move. That's what we call gait. And all these put together forms what we call functional mobility, which eventually prepares us for activities of daily living. So we developed this construct that mobility would have a bidirectional association with community, because the community provides a platform where the mobility occurs. And whereas mobility is essential for us to develop our community even further. And two of them would have an association with our quality of life. So this very work was anchored on the conceptual framework developed by the WHO called the International Classification of Functioning, Disability, and Health. So the green parts was added by us because we believe that environmental factors and personal factors make up sociodemographic factors, which ultimately has an influence on our activity or its limitations, and has a bidirectional association with participation or its restriction, and some association with body impairments, which ultimately would have an influence in mobility and its limitations. So the work was theoretically anchored on the life course and social determinants of health theories. So we believe that socially constructed factors like education, employment, housing, and so on, the accumulation of them over time from when we were born all the way to when we get older would eventually affect our both quality of life and our life outcomes, including mobility. So some researchers have already published relationship between some socio-demographic factors and health outcomes, especially mobility. And we saw in the literature that increasing aging leads to increase in mobility limitations or even disability. And also we saw that people that are married, older adults that are married or has partner may have better mobility outcomes than those that are widowed or single. And we saw a lot in literature that being a woman might have association with mobility limitations. We also saw other research on the influence of education, occupation, income, social status, race or tribe, location, housing, and religion. A systematic review meta-analysis we did as a part of this work, where we looked at 17,170 papers from 1947 all the way to 27th of November 2023. We selected 57 papers that are related to the topic we're talking about today. And we found out that 21 out of them were published in the US. And the publications in US were almost 100% of publication in the whole North America, whereas the other remaining ones were scattered across the globe. Majority of those publications was done in the year between the year 2000 and the year 2020. So, but there's something interesting. We don't have enough paper that were specifically designed to look at the association between social-demographic factors and mobility decline. Rather, some social-demographic factors such as age and gender or race and education were used as a stratifier in this analysis, rather than being a primary focus or as a predictor in such studies. So the summary of gap in the literature is that though we have some papers on biophysical and psychocognitive influences on mobility decline or mobility limitation in older adults, there's sparsity of papers that talked about social demographic factors. If we saw some papers, they will be predominantly descriptive without inferential analysis of social demographic factors. There's very few longitudinal studies, and there's scarcity of disaggregated analysis. There's also paucity of systematic reviews in this topic. So the objective of this current paper I'm presenting to you was to examine mobility changes over time using the CLSA data. So we did a CCS tracking in this instance. Another objective was to investigate how social demographic factors such as age, gender, and so on influence mobility decline that we checked in the first objective. We also used the opportunity to validate 4-meter walk tests using time up and go test as a standard criterion. And we made attempt to classify these factors we identified as modifiable and non-modifiable, so that we'll be able to proffer some policy actions for them. So methods now. This is a secondary analysis of CLSA's comprehensive cohort, comprising the baseline, follow-up 1, and follow-up 2. And the CLSA, as we all know, is a national bilingual longitudinal study that started in 2011 and is ongoing. And the comprehensive cohort we use here comprised 30,097 persons that were aged 45 years to 85 years at baseline. The comprehensive cohort I'm talking about, the data was collected in person, and the data included some sociodemographic factors, biospecimens, physical measures, including time up and go and 4-meter walk tests. The follow-up was in every 3 years, and the investigators hoped to follow up for at least 20 years. The sample in this very presentation is 3,882 participants aged 65 years and older at baseline who completed all the 3 cycles, and they never lived in the long-term care within this period, CCS period of follow-up. So there were actually 108 persons that transited to or from the long-term care, and they were excluded because there are other research out there that show that living in long-term care even predisposes people to more mobility limitations. So we based on people that were dwelling within the community. So ethical approval was given from the University of Alberta, and the ethical approval number is given in the screen. So the primary outcome was time up on go and 4-meter walk tests. And these 2 measures has been shown to be valid and reliable measure of mobility in older adults using simple tools such as stopwatch and the meter rule. So the diagram by your right is schematic diagram showing the time up and go tests, how it's being conducted. So the explanatory variables, the sociodemographic factors include age, sex, marital status, home type, religion, retirement status, social status, and so on. The social status was measured by MacArthur's scale of 10-step social ladder. The covariates were smoking, alcohol use, chronic disease, status, and general health. So the analytic lens is we thought that age is going to be a moderator between the parts of social-demographic factor and mobility limitation, whereas health status will be a mediator and the environmental factor will be both co-founder and covariates in some instances. The directed activity graph where your right side is showing that for a pure association between social-demographic factors and mobility decline, that aging process and health status will be some progenitors here, whereas environmental factors would be a part of the ancestors of the exposure. So there'll be a need to control for environmental factors to see this association. So the software for the data analysis was SPSS version 28 and RStudio, and we applied the weights, both the analytic and inflation weight in the CLSA to complete the analysis. Did descriptive analysis, test assumptions that are relevant for all the multivariate tests we did. And when the test failed, for instance, time up and go and 4-meter walk tests were skewed, we applied log transformation, natural logarithm transformation, in order to kind of correct that and continue with the analysis. The exact inferential tests we used were chi-square for hypothesis 1, which checked if there are variations in the distribution of the social demographic factors between the baseline follow-up 1 and follow-up 2. And for the second hypothesis, repeated measure ANOVA, misdesign repeated measure ANOVA was used to check whether there are differences in mobility decline across categories of the social demographic factors. Then the third hypothesis was a zero-order correlation. We applied a zero-order correlation to check the association, the crude association between each social demographic factor and mobility outcome, which is time up and go and 4-meter walk test, both at baseline, follow-up 1 and follow-up 2. Then the fourth hypothesis had to do with the multivariate regression, where we now check the longitudinal, the influence of the social demographic factors on a longitudinal pattern. And we did that for baseline, did that with first follow-up, that's after 3 years, and the second follow-up, that's after 6 years. And the last one was a correlation, a concurrent correlation between time up and go and 4-meter walk test in order to establish the validity of 4-meter walk test using the time up and go as a criterion. And these were the results, summary of the results, that at baseline, 52% of these participants were women. And this looks similar to what we have in other large national representative Canadian data sets. 70.4% were married. And like I said before, the participants' overall sample size was 3,882. The mean age at baseline was 68.82. Time up and go value 9.59, and 4-meter walk test 4.29 seconds. We saw strong concurrent validity between time up and go and 4-meter walk test. 0.65 Pearson correlation coefficient at baseline, 0.74 at follow-up 1, 0.75 at follow-up 2. We also saw, using the benchmark of people that walk slower than 1 meter per second, we also saw about 57.7% at baseline of people, of proportion of these participants were at risk of mobility limitation. So the CCA mobility decline predictors, I'm telling you about the multivariate regression now, the longitudinal regression, was being older, being a woman, being retired, being Canadian born, being non-Caucasian, being a tenant, having no spouse or partner. There was a kind of a mixed result for household income and wealth, while household income that didn't really suggest a better outcome. Wealth or saving was suggested better mobility outcome. So lower social status, lower education, and some living in some provinces compared to others were also some of the determinants. So this is the linear trend. So this is a plot of the time up and go at baseline, at follow-up 1, and at follow-up 2, that is 6 years later, as well as that of 4-meter walk test. So what I want you to observe is the ribbon. There's a larger ribbon that is the showing that there are a lot of variances in 4-meter walk test compared to the time up and go test. And this aligns with what we have in literature, where researchers has found out that time up and go test is perhaps the gold standard and most valid instrument, one of the most valid instruments in measuring mobility among older adults. And this is a very popular instrument and has, the last time I checked, we had up to 16,000 citations already. So prevalence and risk. So we're talking about habitual gait speed now. So we're using information from the 4-meter walk test, where the speed is distance, a fixed distance moved divided by the time taken to complete it. So if we do that, we can convert the 4-meter walk test to the habitual gait speed of the participants. And if we use the benchmark of people that walk slower than 1 meter per second, we found out that at baseline, that 57% were at the risk of mobility limitation, and their average age was 68 years at then. 3 years later, the average age of these participants became 71.8 years, and the risk of mobility limitation has increased to 63%. And 6 years later, the average age became 74, and the risk has increased to 71.2%. So we can see this consistent trend that as they continue to age, or as the mobility difficulty or limitation increases, so as also the risk in terms of the benchmark of a habitual gait speed of people that walk less than 1 meter per second. So the other one is interesting. The other one is time up and go. Universally, there's a benchmark of 13.5 seconds for time up and go. People that take more than 13.5 seconds to complete time up and go are said globally to be at high risk of fall. So when that was tested on this data set, we found out at the baseline that 3.2% were at the risk of fall, and 5.4% were at the risk of fall after the first follow-up. And the second follow-up, there was kind of threefolds increase in the risk from the baseline to 10.2% being at the risk of fall. All these are very important for clinicians to be able to follow up. We call them like yellow flags in clinical settings, so for clinicians to be able to follow up with their patients. So this is the result from the mixed design repeated measure ANOVA. And I'm presenting the plot of marginal means versus the cycles of the CLSA, which is baseline, follow-up 1, and follow-up 2. And we can see clearly the ones in green are the ones that have better mobility outcomes. So I'll be telling you more about the TUG and neglecting the 4-meter walk test, because we've established that TUG is actually a better measure than 4-meter walk test. And you can see from these graphs and the other graph I'll be showing you some kind of overlap, some kind of kinking and all that of a 4-meter walk test, proving further that the TUG measure is more stable than this. So we see clearly here that people 65 years to 69 years had better mobility outcomes, both at baseline, both at follow-up 1 and follow-up 2, than people 70 to 74 years. Another thing I want you to follow in these graphs is the deviation from the follow-up 1 point and the follow-up 2 point. Deviation upwards means more time spent completing the text, which is more mobility limitation. You will actually see that if the older people had more mobility decline going from follow-up 2 to follow-up 1 to follow-up 2. The same thing for gender here. The male participants had a better mobility outcome than the female participants. And I move a little bit faster. For country of birth, we saw clearly that people that were born in developed countries Here, Organization for Economic Cooperation and Development countries, compared to people that were born in Canada. Canada is among that, but compared to people born in Canada, so excluding Canada, they had better mobility outcome. And people born in other low-income countries that are not members of that classification had worse mobility outcome. Then for ethnicity, it appears that English people that identify as English ethnicity living in Canada had better mobility outcome than any other people, including people that identify as Canadians, whereas other ethnicity lumped together with the French had similar outcome. Cultural identity. It's very clear and obvious here that Caucasians had better mobility outcome than non-Caucasians. In terms of marital status, married people had better mobility outcome than people that were not married. I mean, older adults and had no partner. They include both singles and both people that were widowed and so on. But an interesting thing is that it appears that in the long run, their decline is reducing relative to the decline seen in married people. But overall, both in baseline, follow-up 1 and follow-up 2, those married people had better mobility outcome. So in subsequent CLSA waves, we will be able to know if these two graphs are going to meet or what happens in future as we keep on tracking. So in terms of area of residence, it appears that rural dwellers had better mobility outcome in this crude analysis. When we go to the multivariate regression, the whole thing reverses. For home type, it appears that people that live in their own homes, like semi-detached or completely detached homes, had better mobility outcome than people living in condos and apartments. And we think that the reason is because of the level of activities in the houses, yard work, gardening, cleaning, snow shoveling, and all that, compared to climbing the stairs from basement going to the upper floor, compared to the people that live in an apartment that use elevators and so on and so forth, and do not have certain kind of obligations relating to yard work. So in our qualitative studies, our participants told us the reason for all these things we saw in the CLSA. And this is one of the things they were telling us. So they were saying that obviously, if you live in the older adults that continue to live in detached home, in their own homes, are not institutionalized, that they keep on doing things, which has implicit physical activity. And the more they keep on doing, the more they remain mobile, like they maintain their mobility and don't have it decline over time than people that transit to institutionalized care or this kind of apartments as we're seeing here. So the same with home ownership. It appears that homeowners had better mobility outcome than tenants, but this can be a reflection of socioeconomic status, not just the tag of home ownership. The province graph is so messy and complicated and keep on changing as we run different types of analysis. It appears it wasn't a stable variable. So I would explain further when we go to the regressions. So in terms of level of education, it appears that people that have higher education, higher certificates above secondary education had better mobility at baseline, but the gap started closing very much from follow-up 2 to follow-up 1 to follow-up 2. For occupation, there's another variable that is interesting. You can see some crossing over and overlapping. So the qualitative study participant told us that though the people that do manual work initially may have some mobility challenges, but if you're doing excessively non-manual work, kind of a sedentary work, you sit down all day in office, it also predisposes you to chronic diseases and eventually might lead to mobility limitation in later life. So it's kind of a double-edged sword, both occupation type and both income levels. So in terms of social status, it appears higher social status has better mobility, and it appears that people with no religious affiliation had better mobility outcome than people with religious affiliation, although they started at the same level at baseline. And finally, for the graphs, it appears that people that in this crude analysis, it appears that people that have higher household income had better mobility. But when we went to multivariate regression, that gain was seen lost. So the total household income was not a significant factor anymore, but wealth remained a significant factor all through, even in multivariate analysis. So people that had higher wealth and savings had better mobility outcome, both here and in the regressions. So here we come to the regression, and in this regression, because we're talking about that an increase in the outcome it could be interpreted as higher mobility decline or limitations. So the factors on your right, as I'm showing you here, the right of this line shows people that have worse mobility outcome, while the ones at the negative region here are factors that have better mobility outcomes. So by far, increasing age leads to worse mobility outcome. Here, compared to females, being a male tends to slightly be beneficial or kind of preserve mobility or kind of leads to a better mobility outcome. The other one is marital status compared to people that doesn't have partner. People that have partner has better mobility outcome. The people born in OECD countries, excluding Canada, had better mobility outcome. And compared to non-Caucasians, Caucasians had better mobility outcome. So the other one is in province. I told you already that our resulting province will be interpreted with caution. But here in this multivariate model, it's showing that compared to people living in Ontario, people living in Quebec had better mobility outcomes. The other ones that are of interest is the total household income, which either not significant or rather translated to a worse mobility outcome. And this we saw in the study we did in Nigeria, because we also analyzed in Nigeria the Canadian Longitudinal Study on aging. And it appears that people that earn more in Nigeria had worse mobility outcome in later life. But we were able to associate that to the kind of work they did. Very wealthy Nigerians had sedentary lifestyle, and they were prone to chronic diseases, and they eventually had higher mobility outcome at later life. But the opposite of it is investment. It appears for all levels of investment that people that had higher level of investment had better mobility outcome. So, and this is education. You saw in the graphs that it appears that people that had higher level of certificate, attend higher certificates, had better mobility outcome. But in this multivariate model, it wasn't true when we controlled for every other factor. So the participants of the qualitative study told us that it's not about acquisition of high certificates, but literacy, level of health literacy, and even health belief systems. So that some people might have PhDs, have masters, but that doesn't really translate to, their health belief. So that it depends on the information available to you and how you are able to use this information. So other ones that are very worthy of note would be the chronic disease. Compared to people that don't have chronic disease, people that had at least one chronic disease had a worse mobility outcome. Compared to people that had poor, that self-perceived poor general health, people that had better general health, perception of their health, had better mobility outcome by far. Now we'll ask, what if these sociodemographic factors, especially the modifiable ones, change over time in these 6 years? Did it bring about a change in the mobility outcomes? And yes, it did. So compared to people, if the marital status change from having no partner to now having a partner, the mobility outcome improved. So if the social ladder changed to being low in the social ladder to now becoming high or moderate in social ladder, the mobility outcome improved. There was no significant association with religiosity, but it compared to people that had remained at the same state of their religious frequency or religiosity, being more religious would rather even tend to push them towards worse mobility outcome. So then gain in education improved mobility outcome. And compared to people that went to condo, people that remained in their home, in home detached houses, had by far better mobility outcome. So the last one about rural, compared to people that went rural, people that remained in city had worse mobility outcome. So, and this also, the meta-analysis of our systematic review kind of concur with that, where a lot of studies were showing that older age has a kind of association of with more mobility limitations. And again, being a woman slightly increases the risk of having more mobility limitation compared to men. So this is an insight from the qualitative study I've been mentioning a little bit. And we interviewed 36 participants, 18 from Nigeria and 18 from Canada, and they were saying relatively the same things. The result of this will be presented in this year's CAG, but 4 teams came up, including demographics, socioeconomic, sociocultural, and environmental factors. But there's something interesting. When we're doing the CLSA analysis, we didn't think climate is an issue, but the participant told us climate is an issue. They also told us diet is an issue, and they provided more depth on race, tribe, and cultural issues, including some kind of intersectionality between race, gender, and age, like ageism, sexism, and racism, intersectionality, according to the participants, had a tendency of worsening even mobility experiences. So a retired teacher from Canada that was 80 years when we interviewed him said, I think we are more exposed to climate. You know, we are out in the environment, and the weather in this area, of course, the wind is the major factor, followed by heat waves in the summertime and cold in the winter. And the other person that is a retired nurse that was 78 years when we interviewed her said, well, if you don't eat the proper food, it will affect your bones and your brain. So we have the Canadian Food Guide. As you know, there's a lot of obesity against in the years when people cooked their own food. Some, and she was referring to regulatory agencies, needs to, someone, and she was referring to regulatory agencies, needs to determine how much fat or sugar could be in products. So she wants some regulation of what we buy in the grocery stores. So, and we asked them, what do you want to be done? And they said communities and governments should improve health access, especially for rural dwellers. They also said make public spaces, buildings accessible, considering people with various levels of mobility. They also said address the threat of food, housing, social and financial insecurity. And they also said involve older adults in decision making. So in conclusion, few studies in literature has talked about social determinants, social demographic factors, and its association with mobility decline outside of the USA. So there's need for more study in this area. And the CLSA baseline showed us a TUG, time up and go test value of 9.7. The global estimate is average. The global average is 7.67. Remember, a smaller figure is better with this confidence interval I'm showing on your screen. And the range actually is between, global estimate range is between 5.7 to 12.6 from our systematic review. So although Canada is somewhere in between, but there's need to do better because Canada is generally lower than the global average, making us say there is high prevalence of mobility limitation in the CLSA data. And CLSA is a national representative data set, which have been shown to provide same results with bigger data sets, including the CCH and even some analysis done with Canadian census. So we saw that other adult perspectives in the qualitative study aligned with what we saw in both CLSA and the Canadian Longitudinal Study on Aging. So modifiable factors, sociodemographic factors influence older adults' mobility trajectory. And how we are going to fix it is through social justice, equity, fairness, and fairness. We believe they will ameliorate those factors. So there are some limitations. CLSA's comprehensive cohort may have more urban participants, and it's covered, I believe, 7 provinces. There's this non-randomized sampling self-selection that may favor the educated people. So rural dwellers, new immigrants, people of low economic status, and Black people, indigenous people of color may be underrepresented. Of course, with all other longitudinal studies, there is issue of missing values and attrition, though we didn't see much of that in the analysis we did. They occurred mostly during the follow-up 2, which came close to the COVID era. And, secondary analysis is limited in terms of the variables available to you for the analysis. So the policy implication is that we need to advocate for policies that are culturally sensitive to tackle existing disparities, reassess outdated national aging policies, and incorporate relevant international treaties and declarations, enact legislations that safeguard the rights and privileges of older adults to ensure sustainability and continuity of particularly when we have political changes. When we change party and they come with new ideology, if we've made policies into laws, those policies are protected. Should guarantee security in financial, social, physical, and nutritional aspects. Implement targeted health intervention, including insurance coverage inspired by the WHO's Decade of Healthy Aging initiatives, and invest more on infrastructure that will support aging in our community, in line with the WHO's age-friendly community and cities initiative. So moving forward, so this is all about trying to improve participation, health, and security, belonging, inclusion, and diversity. So I know about this study that was done 12 years ago, and it's a systematic review of the Canadian provincial, territorial, and federal government aging policies. I don't know if there have been an update of this, but I think if we don't have an update of it, it would be interesting to see if things has remained the same in the last 12 years in terms of policy of aging across Canadian provinces and even at the federal level. This will be imperative as the United Nations, in collaboration with the WHO, are reviewing the national policy on aging among member nations, trying to see how much implementation in terms of social prescribing and the incorporation of social determinants of health is going on in those policies. So recommendation for future studies to keep on exploring to uncover more social demographic factors, use a longer follow-up period, do more of intersectionality analysis, do even disaggregated analysis like we did with the Longitudinal Study on Aging, and we hope to do with the CLSA in future. And there's need for universal discussion on scale of measurement and the meaning of multi-dimensional social demographic factors, such as education. So are we measuring health literacy, or are we measuring the level of certificate you have acquired, whether you have a degree or a master's or a PhD? Is that what matter, or the what they call it, the health literacy itself? Again, in religion, are we measuring spirituality, or are we measuring the social participation that comes with religion, or are we even measuring the psychocognitive behavioral changes that comes with religion? So, and these are my references, and I thank you for paying attention to the presentation, and I will be ready to take some questions. Thank you so much.
Great. Thank you for the excellent presentation. And so, yeah, we will open up for some questions now. Again, please put those questions into the Q&A box at the bottom of the Zoom window. So the first one, did you adjust or stratify your analysis by socioeconomic and social network or loneliness statuses?
Okay, so in the multivariate model, we adjusted for some covariates like a health status, like some behavioral aspect, like consumption of smoking, consumption of alcohol. But in terms of loneliness, we didn't adjust for loneliness, and we didn't stratify the analysis for loneliness. That's a very interesting question, and that is a very important place to go to. So in future, we're trying to see if social factors relating to social capital, loneliness, social isolation are also a factor that can predict social mobility decline in older adults. Thank you.
Thanks. Next, thank you for the presentation. Great research. How many participants are from Newfoundland? Was it similar for the 3 time points?
Okay, so in the full paper, we were able to do per province kind of stratification of participants, but I don't have the information on my head as per number of participants that came from each of the province. But I know that in the comprehensive cohort, the data collection didn't cover all the provinces in Canada. It covered about 7 provinces in Canada. So I would go back for sure and check if Newfoundland was a part of where the data was collected. You never can tell, it might not be a part of data collection to start with. But when we look at the paper itself, we'll be able to see these details. Thank you.
Thanks. Someone can correct me if I'm wrong, but I'm fairly certain that Newfoundland is part of the comprehensive cohort.
Yeah, I don't have the information offhand.
Yeah, no, that's fine.
Yeah.
As a CLSA representative, I think it's Saskatchewan, PEI, and I can't remember the third one that's not part of the comprehensive cohort. But anyways,
Okay.
So was having a household pet considered a mobility factor? If not, why? And if yes, what was the outcome?
Was having a household what, please?
A pet.
Oh, I see. Okay. Yeah, in this analysis, we didn't include having a pet. We didn't include having grandchildren at home. We didn't include the number of adults at home. But in other analysis I've done before, not about mobility in older adults, but in adults, kind of physical activity in adults. We found that having a pet, especially having a dog, was a significant correlate of having more physical activity because of the obvious reason of walking the dog and all that encourage the owner to also take some walk in terms of physical activity. Yeah, so there's a difference between level of physical activity or physical activity participation and mobility in others. So mobility in this study was kind of used as a prognostic, kind of a diagnostic criteria that's related to other general health outcomes.
Great, thank you. So we have one comment, very interesting study and an excellent presentation. And then excellent presentation. Your policy recommendations, while laudable, are very broad. Can you talk more about practical national and provincial policy initiatives that could be useful in Canada?
All right, I showed Wilson's paper, although that paper was done in 2012. That paper is very rich and comprehensive. They compared all the provincial policy on aging, bringing out issues like where there are discrepancies in housing. Some provinces provide more for housing for older adults, while some provide more for post-retirement engagement in socio-economic activities like employment in certain places that older adults can do that doesn't have much stress but still keeps them engaged and active. So it will be interesting to go back to, although that paper was done, like I said, 12 years ago, to look at that paper, and it will give us a very clear kind of map of what is being done, what is available, and they also made recommendation on what could be done to improve it. But at the global scale, like I said, the United Nations this year, in partnership with the WHO, through the 2020 to 2030 Healthy Aging Initiative, have been looking at the policy of aging among member nations. I think at now, just less than 80% of member nations already have and have enacted like national policy on aging. But they are going further to see how much social prescribing is coming in the area of primary health and for physicians, and how much factors of social determinants of health. WHO talks a lot about social determinants of health is being incorporated in this, and they will be, you can be broken down into issues like housing, issues like food security, issues like financial security, social security. But the participant that talked to us in the qualitative study talked a lot about having some kind of rebate for services, especially services, social services, or services that make older adults to participate in, kind of physical activities and so on and so forth, like swimming, like physical activity classes, or just coming together in community halls and interacting with each other and having free coffee and going home. I can remember one retired judge that we interviewed that said he knew about some older adults that doesn't have family or friends, and nobody knows of their existence. They just live in a condo and they feed through food on wheels and all that. And he was advocating for us to even have a register where these kind of people can be identified, so that if there is something like a pandemic or emergency, we will know where they are and go and find them out. I'm also advocating that the Institute of Aging under Canadian Institute of Health Research should maybe provide some other thematic funding areas for mobility in older adults.
Great, thank you. So the next question, so a comment and a question. Like in Nigeria and Ghana, the wealthier individuals have more sedentary lifestyles, but it seems here in Canada, it is reversed. Any thoughts on how to address the resulting disparities in Canada, how to tailor to address mobility disparities in a culturally sensitive and community specific way, especially among immigrant older adults who have different cultural norms?
Okay, that's a very important question, and thank you for that. So, yeah, the issue with social demographic factors or social determinants of health is that there is some linkages, there are some overlaps, and if you look at the intersectionality, you start understanding things a little bit better. So people don't just get wealthy. So it's kind of have a link between the exposure to education and opportunities, then which kind of correlates with the kind of a job they will eventually do and make money from those jobs, or else they had a kind of generational wealth that was handed down from generation to generation and they inherited it. So if they make that money through working, then education becomes an issue. That's where education comes in, giving more opportunity, then opportunity for more income. Then the argument was that it seems that people that have high earning jobs do more of sedentary work in their middle age. In fact, there's a systematic review that talked about the kind of job people do in their middle age, how it eventually cumulates to mobility issues, including general health outcome at the end of life, or later life rather, not end of life, later life. So I don't know for sure if, for instance, the most wealthy people in Canada will be the most active people in Canada. But when Canadians were interviewed, they were saying that the essence of having money is to be able to afford services like health services. Like I interviewed somebody that was a librarian, and she said that she had a surgery and the surgery cost her a lot, and she was not able to stay in waiting list in Canada for long because she had her money. She had to go to another country to complete that surgery and all that. And she was like saying, assuming she was living paycheck to paycheck, she was not going to be able to do that. So while that's having a lot of wealth is protective in terms of making you be able to afford these services, we're looking at a longitudinal, like at a life course pattern of it. Do these people had enough time to take care of their health when they are accumulating this wealth? What is the nature of the work they were doing? Would the wealth eventually purchase the lost years of being active and maintaining mobility when they eventually retire? Then coming to the cultural aspect of it, we also saw that culture plays a lot of role. How in Nigeria, for instance, and some part of Africa, for instance, the belief that when you're getting older, you should be slowing down, taking things easier, relaxing. And if you're rich, you should be relaxing and enjoying life. But in Canada, it appears that there is this knowledge and this willingness to keep on being active, taking a walk and all those things. So that's where culture comes in. So I am not very vast in Canadian culture, and I will not be an expert to prescribe what will be most culturally appropriate. But I have collaborators who we're working with are very expert in this area. I'll take this question back to them, and they will be able to kind of address it, and we'll design in our next phase of studies how we'll be able to, in our co-creation studies, interface with other stakeholders and see what will be more appropriate. I'm limited in cultural nuances in Canada.
No problem. Yeah, I think this question was kind of getting at, within some of these immigrant communities where there are the different cultural norms from Canadians, how do we make sure to engage in a culturally sensitive and community specific way so that they're not left behind or left
I
out.
see.
Yeah. Well, I think we will have to wrap up now. So thank you to everyone who submitted a question. I'm sorry to those that we didn't get to. But thank you again to you, Ogochukwu, for your excellent presentation. And we appreciate your participation and the participation of all of you in the audience today. I'd like to remind everyone that the next deadline for data access applications is January 14th, 2026. So please visit the data access section on our website to review the available data as well as additional details about the application process. I also just want to let you know, if you haven't seen yet, that we've introduced an updated data access fee structure. So this is the first adjustment since we launched the platform more than a decade ago. And this update supports a sustainable cost recovery model that will help us to maintain the exceptional quality and stewardship of CLSA data for years to come. For more information, please visit our data access webpage. The link should be in the chat at clsa-elcv.ca/data-access. And finally, a friendly reminder for all CLSA data users to keep us updated on any changes that affect your data access agreements. So if you've moved institutions, your research team has changed, if you have a trainee that's graduated and moved to a new position, you can always reach out to us at access@clsa-elcv.ca with any questions or updates. Now, finally, our next webinar is titled Exploring Mental Health, Cognition, and Sexual Orientation, Advancing Health Equity Through the CLSA. And this will be presented on Tuesday, November 18th, 2025 at noon Eastern by Arne Stinchcombe, an associate professor in the School of Psychology at the University of Ottawa, and Ali Grady, a PhD candidate in the Clinical Psychology program at the University of Ottawa. The registration details are posted on our website and in the chat box. and I'd also like to remind everyone to complete the anonymous survey upon exiting the Zoom session. Thank you all again very much, and I hope you have a great day.